Hello and welcome to another episode of Ringsabellpodcast, the show where I forget everything from pharmacy school, so I invite a guest on to quiz me and then roast me on what I don't remember, in the hopes that I will then remember the things and be a better pharmacist someday when I get to work again. Because kids, by the way, do you like my sweater? Check this out! And my mug? I'm all merched up, and you can be too via the giveaway in this episode. That's right. This episode is sponsored by Thinkwear Collective, a very cool apparel company created by Lindsay Dixon of Friendly Pharmacy 5. What is Thinkwear Collective, you may ask? It's apparel for pharmacists who believe in evidence, humor, and making misinformation just a little uncomfortable. Think mugs, hoodies, and tees that quietly say what you're thinking while supporting evidence-based science communication through podcasts like this one. Thinkwear Collective has generously donated a code for $100 for me to give away to my listeners. Details on how to enter will be in the show notes below. You can go there as well to find my link tree where I have links to all the things you may need, like references from the show, my aptly named semi-useful notes, a sign-up page for my email list, and a link to donate to keep the show going called, quote-unquote, buy me a coffee, which I will then drink in my very cool mug from Thinkwear. And finally, I come across really dumb in this episode. At one point, I actually just forget what a macrolide antibiotic is. And that's embarrassing. I'm going to blame it on mom brain and being sick at the time of recording, and we'll just leave it at that. But please enjoy learning at my expense. Without further ado, here's the show. I have Brad here, Brad Phillips. He is going to interview me on antimicrobial stewardship, which was my least favorite topic in pharmacy school, and then roast me on what I don't remember, which I predict will be a lot. Welcome, Brad.
Hey, Kim, thanks for having me. Very excited to be here.
I'm also very I say I'm excited to have you here, but I'm not excited by how poorly I'm going to do on this quiz.
I'm excited to school you. I don't think I have anything too ridiculous. It's a big topic, so we'll kind of start nice and easy, and then we'll progress from there. But no, I think this is going to be great. Good learning experience for everybody.
Well, just off the hop, so you're working at Hart Pharmacy as a clinical pharmacist.
Mm-hmm.
And that's in Victoria, correct?
That's right. Yeah. We have a few different locations around Victoria proper. I'm working one along Shelburne Street for anybody listening who lives in Victoria. Come say hi. Yeah, we're a really clinically focused pharmacy. You know, it's still a dispensing pharmacy, but we really focus on things like minor ailments, medication reviews, other clinical services. So we usually and try to go above and beyond with that sort of thing. So yeah, really clinically minded, which is really exciting for me, a newer graduate, fresh in mind with all things I've learned from school. So it's been a really fun and great place to start, and definitely a place I can see my future with. So yeah.
Amazing. Hopefully you won't be sitting here in 8 years from now, post-graduation like me, going like, oh, I don't remember a whole lot. I mean, a part of that is because I have been off of work for about 3 years with kid having pregnancies, et cetera, et cetera. But another part of that is that I just didn't start all that clinically off the hop. Like when I graduated, we thought clinical meant we give vaccines and we do, minor ailments. But then you realize that the time you have available, if things aren't set up properly for you, is not really there to do a good minor ailment, or sorry, not minor ailment, med review. So yeah, even when I was still in practice, I felt like my skills were slipping. And I remember someone saying like, yeah, when you graduate, you're at the top of your game clinically, you're going to lose it fast. And I thought, that's not going to happen to me. It
does. And well, when the landscape's changing so much, I mean, in those 3 years that you were away from, day-to-day practice, like so much has shifted in Canada and in BC in particular. So it's, totally fair, totally, I think, warranted that little behind, especially clinically, like just so much changing, which is why
Mm-hmm.
it's just an exciting field to be in, pharmacy. It doesn't seem like it. I think maybe most people don't have the most glowing, like, oh my God, my pharmacist is like so cool. But it is a really cool industry if you're in the right places. So
Totally.
mhm,
Well, very happy for you that you landed at Heart.
me too.
They seem like a great employer. If I lived in Victoria, I probably would have been bashing down the doors to get in at Heart, but that is not the case. I'm in the interior. How did you know you wanted to get into pharmacy? Did you know right off the hop, or was that sort of a late
Yeah, I think
thing?
I think I went through the typical, younger, kid that likes biology / animals and went with that. Oh, I'm going to be a veterinarian because that's what everybody says if they like animals and they like biology. But I think I became less enthralled in the idea of having to like actually touch and do specifically hands-on stuff like that, among other things. But my mom's a pharmacist, recently retired. My aunt is a pharmacist, recently retired. My grandfather's a pharmacist. And it wasn't a sense of, oh, you have to do this. It was never like pushing, but I saw the lifestyle that pharmacy provides and all these great interactions she got to have, especially my mother, with all of her patients and all of her clients, and really social field that also really focuses on science, biology, anatomy, like all these really interesting things. It seemed like a really great combo of all those things I enjoyed. And knowing that unlike maybe a doctor's office or if I was in medicine, I'm going to be on the clock 100% of the time. I never have time to just not be on. So I think this is a really nice medium between the two. So I didn't know right away, but I knew like grade 11, grade 12, like, yeah, pharmacy's the plan. So pretty early, probably earlier than most. But I did have a little bit of influence. Plus I figured that if I had any questions come up in pharmacy school, I had some aces in the hole to answer those questions. So I figured it was a good place good angle to go with.
Oh, wow. Okay. So you knew really early. Also, sorry to all my listeners, I'm sick with something from my toddler. So, I'm going to sound real weird and I'm going to use it as an excuse not to answer very well is what's going to happen here.
That's fine. Yeah.
Okay. Wow.
Anytime there's a pause, I'll just be, oh, she just sneezed. Sorry, everybody.
Yeah. Don't worry about that pregnant pause. That was my illness, not lack of knowledge. Okay, well, let's get started on the quiz.
Okay, yeah, let's pull up these questions. So again, trying to start it just like fairly straightforward. So I apologize if these are too easy. It's kind of hard to know, again, I think coming right out of the gate, like where my mind is fairly fresh with a lot of these ideas. I don't know what is considered easy and not, you know what I mean? So, I do not feel bad in any regard about how this goes. And we'll just kind of see where this takes us. So my first few questions kind of relate to how we classify bacteria in general, because that does have a big impact on how we choose different antibiotics and what to go with. So pretty straightforward question to begin with is just as far as like the most simple classification of bacteria, what is the difference between a gram-positive bacterium and a gram-negative bacterium? What's the main thing?
It's how they get stained on a slide, and it has to do with the outer membrane.
Yeah,
I think
pretty close. Yes. So is that final answer?
Oh God, gram positive and gram negative. There's like there's staining. Yeah, I don't.
Got it. Well,
hit
again,
me with it.
Very much in the right realm. So with the whole thing with gram staining is a crystal violet stain that you apply to the bacteria, and then you do a wash, and then it kind of results in two different images. Gram positive, it's usually that more purple color, and that's because the stain grabs onto the thick peptidoglycan layer in gram positive bacteria in their cell wall, very thick layer, so it stains it. That peptidoglycan, such a mouthful, peptidoglycan layer in gram-negative bacteria does exist. It's in their cell wall, but it's very thin, so it doesn't really grab onto it. Plus, gram-negative bacteria have an outer membrane as well as their regular inner membrane, cytoplasmic membrane. So there's a few things that separate them, but it's based on how that gram grabs onto that specific layer. And the only reason I bring that layer up is that it does have an impact. That's quite a common drug target for antibiotics to help to destroy them. So that's why there is some importance to that, but I assure you that will never come up in practice. I can't imagine anyone asking that.
Right. Okay, so
Why would they
sorry,
want
I was like fiddling around with my mic because it started to fall over
Oh, no.
off of the table. So one of them, gram-positive or gram-negative, has the peptidoglycan layer.
They both do, but gram-positive, it's extremely thick. The gram-negative, it's quite a small layer.
Okay, and so that's what's getting stained and
Or
showing
not.
up differently or not. And then
Yes.
the gram-negative has the extra layer of...
Yeah, they have an outer membrane. It goes outer membrane, thin peptidoglycan layer, and then the regular cytoplasmic membrane. So there are multiple layers. And again, not only is that a thinner peptidoglycan layer, but it's all in the inside of that outer membrane. So there's nothing really for the stain to grab onto when we do that wash. It just comes off right away.
Got it. Okay, cool. So I knew like something.
Yeah. Oh, yeah. I thought that was good. You weren't off.
I wasn't off, but I wasn't on.
Yeah. Lots of time. That's just one question.
Lots of time. We'll work into this. It's going to get better.
Exactly. All right. Ready for the next question?
Yeah, kind of.
All right. So next one, talking more specifically about antibiotics themselves, but again, classifying them, some early classification stuff that, again, probably would never come up in practice. Certainly not something you would have to talk to a patient about, but good to know just how certain antibacterials work. So 2 different classifications. What's the difference between a bacteriostatic antibiotic and a bactericidal antibiotic? Kind of comes with the name.
Yeah, the cidal one kills them. And the bacteriostatic just like halts their growth.
Exactly, which allows our immune system to clear it more easily. So you nailed that one. So 1 for 2, pretty good. You're on the board.
That's like my pharmacy school grades.
Yeah, great. So you get degrees. We're all here. We all made it.
Yeah, we all made it.
All right, moving on to the next one. A little bit more difficult, and this is one I had to relearn, honestly. But another kind of classification split. What's the difference between time-dependent and concentration-dependent killing when it comes to antibacterials?
I'm going to assume that has to do with like one of them you have to get to a certain level of antibiotics. So those would be the ones you're using like a loading dose of to actually help. And then the other ones would be just like it takes a bit of time once they're in there to do their thing.
Yeah, sort of kind of on the right track, but it's a little bit different. It kind of has to deal with the MIC, which is also known as the minimal inhibitory concentration. That's just the lowest amount of an antibiotic to cause antimicrobial, like stop antimicrobial growth. Time dependent, it doesn't really matter what the concentration is, as long as it's above that MIC. It's the time that you're spending over that MIC where it's effective. So the concentration doesn't matter. The most important parameter is just that time above that concentration. Concentration dependent basically means it's more effective at higher doses, and those more deal with how high you actually get that concentration. And essentially, if you're looking at a graph, the area under the curve, which is, again, more of an abstract thought, but basically it's once you hit a certain concentration, it doesn't matter as long as you're above that MIC. They prefer it for more than 50% of your typical antibiotic course. If you're above that MIC for more than that, you're good. It should work properly if the bacteria is sensitive to it. And then concentration, just the higher the dose, the more effective the drug is going to be. So again, a little more abstract with that one. I try to picture that in my head using graphs, and even then it's kind of hard to comprehend. But again, luckily it doesn't come up super often. But
okay,
based on the last 2 things we chatted about, an example, what are penicillins? Are they bacteriostatic or bactericidal? And then a follow-up, are they time or concentration dependent?
Whoa, he's making me draw connections. Okay, so penicillins are, I think they're bactericidal.
They are, yes.
Because I remember there being like, resistance via cell wall, like beefing up the cell wall. And so that makes me think that we were actually killing them by bursting them open.
Exactly.
Yeah. And I think that they are time dependent.
You nailed it. They are time dependent. Yes. Well done. Yeah.
Hell yeah. Okay.
You're right. For most things, we don't really, with penicillins, the dose is obviously important. It always will be. But most drugs are time dependent. Most antibiotics, I should say, are time dependent. Some examples of concentration dependent are ones you don't really see in practice, like aminoglycosides, like at least in community. I'm not seeing that ever because none of them are oral options.
Right.
But those are a good example of concentration dependent. I think fluoroquinolones are also considered concentration dependent. But most other ones are, yes, are time dependent.
Are time dependent. Okay. Okay.
All right.
Excellent.
How are we feeling after those first round of questions? Honestly, to me, because those are the most far detached from community practice, those are the ones that I like are easy, but like I feel are difficult. Like not something I use every day. But how are you feeling?
It's feeling like I'm starting my like engine back up to try to remember just like things that are, again, like you say, in practice, you're not really using that knowledge. You are actively putting that into practice based on, what antibiotic you're using, but you're just like, you're going to bugs and drugs and picking it, and they've done the work for you. But it's good to be reminded.
Absolutely. Okay. Hopefully these are a little more practice-based questions we're getting into that would come up a little more regularly and probably is more interesting / more universally known by you in the audience. So the next question refers to beta-lactams. So that's our big group of many different things. Our penicillins, our cephalosporins, why can't I think of the name of them now? Your carbapenems, and that's one of the drugs. I don't think that's what they're actually called. But anyway, beta-lactams in general. So a lot of people report having allergies to beta-lactams in some capacity, but how can we determine or suggest that there won't be a cross reaction? What is it within the molecular structure of a beta-lactam that determines this cross reactivity risk?
Again, I'm going to go cell wall on you for this. I feel like, oh no, hold up.
Okay.
We are not talking about a bacteria. But I'm going to go like side chain.
Bingo. Absolutely right. Yes. So the beta-lactam is like obviously the key structure of beta-lactams, but it's the side chain that makes them different. So you're right. There are some that are very similar to, like, again, within our penicillins group, penicillins are all very similar. So they're generally considered all can cross-react with each other because their side chains are very similar. But when we get into the outer layers of like second gen and third gen cephalosporins, they become extremely different, which is why it makes them potentially useful alternatives for people that have a penicillin allergy. But that kind of brings me to my next question, unless you have a question about that question.
I feel like my question was going to be, so does that mean that third gen and fourth gen won't cross-react? And you're probably going to ask me a question about that.
Yes, and they're a really great resource for those who wouldn't have already seen this. Again, operating out of BC, the BC College of Pharmacists actually has a fantastic breakdown like chart that shows the cross reactivities, and I use it regularly. But you're right. Usually, as we go into those kind of outer rings of cephalosporins, we definitely get less and less cross reactivity with penicillin specifically. Kind of like a very general rule of thumb is usually if it's like within like second gen, if you or if you have a severe reaction to a third gen cephalosporin, you probably would also react to another third gen, or you'd have that risk. But usually, like if we're comparing a penicillin to a third gen, not a lot of cross reactivity. And I want to make sure I'm not spoiling any of my other questions. No, actually, that I have a few other questions. I will get there. But it kind of brought me into this next idea of, again, penicillin allergy. Probably the most common one. People say, oh yeah, I have a penicillin allergy. And when you ask them, what was it? They're like, oh, I don't remember. I had it as a kid. I am always try to make sure that patients are aware that a lot of the time, almost all the time, if you have especially skin-related reaction to a penicillin, it's very unlikely an anaphylactic reaction or a severe cutaneous reaction like, SJS or TN, because the risk is just incredibly low. So my question is, what is the actual suspected rate of true penicillin anaphylactic allergies in the general population? What is the percentage?
Like between 1% and 3%.
Yeah, and I think that's what people used to think, and that what the kind of general thought process is, but it's actually suspected to be 0.01% have
Oh,
a
wow.
true anaphylactic allergy to penicillin. And yes, there are other types of reactions, again, past anaphylactic, but that's like shockingly low, right?
Mm-hmm.
So that's why I always try to tell people like, hey, just FYI, based on what you're telling me, there's a very good chance if you don't remember like your parents being like, oh my gosh, like we had to take you to the hospital, you stopped breathing, like that sort of thing. Probably not a anaphylactic allergy. Penicillins can have general rashes as a side effect. They can be annoying and bothersome, but they're rarely dangerous. They usually will happen after several days of use. So an anaphylactic reaction would happen within the first 24 hours, if not way sooner. But usually these delayed reactions that are mild are usually like 3 days after starting. So
Okay.
just some other useful information there. And again, it's just good for patients to know because penicillins are like one of the most useful groups of antibiotics classes. So I hate when people come in for a certain something and I ask them what they're using it for and they've been given a different drug that's not a penicillin when I know penicillin is probably the best choice. Like, yeah, I have an allergy. I had this, I don't really know what it was, but my parents said I had like a rash or something. It's like, that's not the best option. Anyway,
okay.
that's
And
a
you're
tangent.
And are you saying like penicillins are the best choice because they're just going to work the best? Or are you thinking from like don't get drug resistance and we can't ever treat a infection again?
I would say that a lot of our most common afflictions, like things that we'll get into that I don't want to spoil, can be very successfully treated with penicillins. And we have been using penicillins for so long. We have a really good understanding of their safety profile as well, which is why they are so useful. So I think it's kind of a multitude of things like use in terms of the actual bacteria they can cover. They're not considered broad spectrum, but still the most common afflictions and just good safety profile in general, super wide therapeutic index. So therapeutic window. So yeah, it's just kind of, they're good. They are good.
Gotcha. They're
Yeah.
good. And you're really potentially doing yourself a disservice. It's funny because I think patients often think, well, I need to be really safe, so don't give me the penicillin because I might react. When in fact, if you actually look at the risks, they could be just going for a more dangerous antibiotic that maybe has a worse safety profile, but we have approved it because we need it to work for severe infections, or we just don't know because it's new.
Yeah, exactly. Or it means we're choosing an antibiotic that shows more resistance to those typical bugs we see in a certain infection. So there's definitely, again, you're absolutely right. It would be a disservice if you're not at least a little skeptical. The other thing is that just like any allergy, people can outgrow even an anaphylactic allergy to penicillins. Now, I'm not usually gung-ho if somebody had a true penicillin allergy and it's been 30 years, there's a good chance they've grown out of it, but I'm rarely going to be like, oh yeah, you'll be totally fine. That'd be something I'd be still very cautious with. But especially folks that had a mild skin-related reaction 30 years ago, like you could probably use this safely, still monitor, obviously be aware of what to look for in a severe reaction, but like you're probably good.
Right. And I guess it's like, it's so funny because before I had kids, I thought of, I would be like, oh, okay, so you had this reaction and your parents don't really remember what it was to be able to tell you, like, that could be any severity. How do I even interpret that? But now that I've had a kid, I'm like, oh no, if it was bad, I would remember it viscerally in my soul. I would remember it and I would be able to tell you exactly what happened and the timeline. Like, that's not just leaving my memory.
Totally. And it seems like for a lot of people that come in, like especially in their early 20s, they'll say they have this allergy, but they don't know because their parents were just like, no, you cannot take this, because the parents remember, but the kid doesn't need to know. They just need to know that they're not supposed to use a sulfa drug or a penicillin.
And I guess their parents got used to telling them when they were a kid and when that allergy was fresh. And people were being because people are very cautious with kids, right? So if you had a rash from a penicillin as a child, the doctors would probably say, like, let's stay away in case that rash progresses into anaphylaxis.
Mm-hmm.
But now we could maybe retry that.
Mm-hmm. Exactly. So, slightly similar question. So, for example, one of the more common indications we see penicillins for, especially amoxicillin, is in treating community-acquired pneumonia, because the most common bacteria that causes that is called, oh my gosh, wait, sorry, I just completely forgot what it is. It's strep pneumo. It's strep pneumoniae. Pardon me.
Also known as strep pneumoniae.
Yeah, get it. Yeah. So strep pneumonia, which amoxicillin is particularly useful against. So we often see that. But in someone that does have, a potential anaphylactic reaction to it, we obviously don't want to use it. So what's another good second generation cephalosporin that is considered safe to prescribe to someone with a history of penicillin allergy, a true one, to treat pneumonia in an otherwise healthy adult? So someone that doesn't have comorbidities, but they do have a pneumonia and they do have a true penicillin allergy. What is a second gen cephalosporin that we could use instead?
Cefixime?
Nope. That is actually a third gen and has terrible coverage of gram-positive. But they all sound the same. So
they do. It's true.
So the one that I'm thinking of sounds very similar. It's called cefuroxime.
Okay.
And cefuroxime is a second gen, very different side chain, is considered a safe alternative, and has actually really good coverage of strep pneumoniae. So, it's a really good option. Recently, I actually had a discussion with our local dentist here. This will tie in, I promise, because another very useful, time to use penicillins and amoxicillin is in dentistry, because it covers the main bugs in the mouth. Some of the anaerobes that live there. It covers them really well. But again, penicillin allergies come up all the time. And recently, I've seen more and more cefuroxime prescriptions. I'm like, wow, this is great. This is actually a really good option. How did the dentist know about this? Because I feel like for a long time I wasn't seeing them, or at least in my first few years of practice. So when this dentist called in a verbal prescription for it, I was like, I'm so curious. I kind of gave him the background. I'm like, this is a great option, especially for penicillin allergies. But I just started seeing it more recently. He's like, yeah, we got a notice from the College of Dentists to side way more towards this drug than clindamycin, which would otherwise be used for another reason that I'm going to get to later in my questioning. But
thank God.
But yeah, it's very interesting.
I remember arguing with a doctor about clindamycin. I was like, bro, this is not needed. And at that point, I remembered what a cephalosporin was. At this point, I'm like, Cefixime was the first one that popped into my head. I was like, that sounds sort of right.
Mm-hmm.
But yeah, I do remember they were just slanging out clindamycin.
Mm-hmm. Yeah. So talking about pneumonia as well, when we consider fluoroquinolones, they're quite a broad spectrum class, and we would consider them for empiric therapy in community-acquired pneumonia, especially for people with comorbidities. But what is the one fluoroquinolone you would never consider in that case?
In community-acquired pneumonia?
Mm-hmm.
Okay, first, let me confirm that I know what a fluoroquinolone is. So we're talking like moxifloxacin, ciprofloxacin, levofloxacin.
Yeah, those are like the big three.
I feel like you would never use Cipro because that's like a diarrhea situation.
Absolutely. Bingo. Cipro, as great as it is, basically only covers gram-negative bugs. It doesn't really touch any gram-positive, and as I maybe should have mentioned before, strep pneumo, very much a gram-positive drug. We consider the other two, moxifloxacin and levofloxacin, respiratory fluoroquinolones because they provide excellent coverage of strep pneumo, as well as some other ones we see more often in comorbid patients.
Okay.
So bingo, you nailed that one.
So that's your comorbid patients, are they having like H. haemophilus influenza?
Yeah.
Is that like the other bug?
Yeah, there's a few different ones. You can see H flu. You can see even see like staph in some of those people. And there's some other types of bugs that are associated with it, which is actually my next question. You keep jumping ahead.
Sorry.
That's okay. Let me find it though. Make sure I ask it correctly. Oh yes. Okay. So, sometimes, again, especially in patients with comorbidities, You can still use a beta-lactam, like you can still use a penicillin, but again, its main purpose is to cover strep pneumo. So why would we consider adding on a macrolide or doxycycline on top of that beta-lactam, like usually amoxicillin or even cefuroxime, for these patients with comorbidities? What are we trying to cover? What are those bugs? Because it's not H flu.
Okay. The only other bug that I remember is the walking pneumonia one, but I feel like is that where we're going? So the mycoplasma?
Yeah, mycoplasma pneumonia and also chlamydia pneumonia are the two ones. They're called atypical bacteria because they don't actually fall into the gram-positive, gram-negative cell structure. So we use azithromycin and doxy because they, in particular, are really good at covering those things. As I should say, azithromycin and doxycycline does still cover strep pneumo, but not nearly as well. And this is one of the tangents I'm going to go on, so I apologize in advance to you and your listeners.
No, do the tangent.
I see way too often, and everyone I work with knows this because I have a vendetta against it. I see azithromycin used alone for chest infections, just chest infections, way too often. Virtually no Canadian resource for treating pneumonia has it being used by itself. Bugs and Drugs does not, unless there's it's the literal only option to do monotherapy. My favorite, RX Files, also does not have it on there. Because while it has great atypical coverage, its coverage, at least in BC, of strep pneumo is 70%, which is really not fantastic. Not something we want to use really regularly, but because we're using it so often, it's just going to get worse and worse,
Right.
And I think walking pneumonia is quite a slang term, quite frankly. There's no actual way to firmly diagnose if something is a walking pneumonia. Obviously, you need to do a chest X-ray and this and that, but those types of infections are very hard to culture because you have to basically get a sputum culture, but that is obviously going to have a ton of other bugs in there because other bugs live within, again, your mouth, your upper respiratory tract. So it's really hard to actually specifically culture that and say, yes, this is definitely a walking pneumonia. That's just a slang term. We don't actually know what that is. We're just trying to cover everything we can. So when people say, oh, I've just had a cough for a long time, it's assumed to be a walking pneumonia because supposedly these, they're less severe, but they slowly progress. I guess that's true, but that's not anything, quite frankly, at least within my research. And again, I'm not a medical doctor, but from my understanding, it's not, Anyway, so all this to say,
I did not know that.
Azithromycin.
I always thought it was I always thought mycoplasma was, yep, you went to the doctor, and let me back up. Maybe at one point I knew this, but it kind of sounds like you have better info and are more interested in this than the average person who survived the antimicrobial lectures at school. Yeah, I was just always under the impression that if someone said they had walking pneumonia, it was we know for sure it's mycoplasma, and that is why we're treating with this.
Mm-hmm. We have no idea. There's nothing that, from my research, nothing necessarily differentiates it, at least in the outpatient setting. I suppose there might be some differences in the chest X-ray, the patterns, I suppose, of the infiltrates if they have them, but they can't culture something like that very easily. And I'm pretty sure because they're atypical, they don't gram stain properly.
Hello, she's back with her first little edit of 2026. And just to keep things consistent, I am also sick today. So I'm going to sound about the same amount of sick as I did on the initial recording. Just a little extra thing I think about for you guys. So I'm here with some more information from Brad about walking pneumonia because he wanted to sort of flush it out a little bit better. He says, so I was right in regard to atypical bacteria because atypical bacteria, bracket C. pneumoniae, M. pneumoniae, Legionella, SP, etc., lack a cell wall. They cannot be properly gram stained, so they are difficult to identify. They require more specialized identification methods such as PCR test. Furthermore, since they are often associated with pneumonia and sputum is difficult to properly sample because it has many contaminants, they would need to be found in the blood to undergo PCR testing, which would mean a much more severe infection requiring heavy-duty empiric antibiotic therapy. The lack of cell walls also makes it difficult to grow under standard culture methods, so they're difficult to even culture. As for diagnosing atypical pneumonia, it can be done based on clinical symptoms, but generally they require a chest x-ray or even a PCR test. For example, typical pneumonia, which is most often caused by strep pneumoniae, usually has a more sudden onset and is associated with a high fever. Atypical, on the other hand, is usually more gradual. However, we need to keep in mind that most respiratory infections are viral and may closely mimic both types of bacterial pneumonia. As for the chest x-ray, typical pneumonia is usually more lobular and dense versus a more diffuse, patchy appearance of infiltrates for atypical pneumonia, but I don't expect many outpatient physicians will perform a chest x-ray. All of this to say, I find the term walking pneumonia thrown around far too often when it's estimated that they are responsible for only about 15% of bacterial pneumonia cases. No guidelines recommend monotherapy with macrolides, other than in cases of severe penicillin allergies, and even when walking pneumonia is suspected, we will still need to treat for strep pneumoniae and add on for atypical coverage. Brad has kindly provided a reference for this, which I will have in my references document. You can find the link to all the links in the show notes below. All right, back to the show.
So again, that's why you look at your guidelines. None of them have just azithromycin for the most part, because we still don't know if something is specifically a walking pneumonia or an atypical pneumonia. We still need to make sure we're covering strep pneumo because that is far and away the most common one. And azithromycin by itself does not cover it very well. And even same with doxy. I was recently surprised because a lot of the resources do have doxy as just like monotherapy, which is fine. But then when I actually looked, at least in BC, at our antimicrobial stewardship dashboard and at Life Labs, it also has pretty not great coverage of strep pneumo. It's like also around 70%. So it's just interesting. To me, it's interesting. Hopefully to you, it's interesting, and to the listeners, but to me, it's very interesting.
Well, I think the listeners who want a refresher on, what resources they should be using if they have a suspicion that perhaps a script isn't quite right.
Mm-hmm.
I remember a lot of times thinking like, where do I go to find this? I don't really remember what's the best resource. So you were mentioning a few resources there that you go to?
Mm-hmm. Yeah. So as far as antimicrobial stuff and like infectious disease stuff, definitely Bugs and Drugs is the best. Bugs and Drugs is awesome. It's a Canadian resource, and it's just really comprehensive. Has a lot of great information there. I also love RX Files. They have some really great stuff on infectious diseases and just antibiotics in general. I'm usually kind of cross-referencing between those two. But resistant patterns specifically, the BC CDC has an antimicrobial resistance dashboard that shows general or just shows like antibiogram data on it. I'm looking at it right now, and you can even search based on the year, which is very interesting. You can also literally just look up Life Labs antibiograms, and you can pull up, in BC at least, certain parts of the country in both outpatient and inpatient, which is very interesting. The last one I also think is fantastic is a resource called First Line, which is a little more oriented towards like inpatient care, like hospital. But it also is a fantastic resource for finding standard dosing, recommendations, looking at pathogens and their both typical like resistance patterns as well as actual antimicrobial data. So I'm usually going back and forth between all of these different things when I have a question like this. Those are my favorites.
Okay. Which is yet another reason that practicing in the right spot is important, because I don't know how many places I have worked where you don't really have access to a computer when you're checking scripts. Like, what?
Totally. So yeah, it makes a difference, at least to speak from my own personal experience at Heart. For the most part, the pharmacist is at intake. So, at intake, we can directly talk to these patients and we'll kind of do more of a deep dive than rather getting at the very end when everything is already prepared and it just needs to be checked. So we can kind of catch some of the weird irregularities kind of up front and that sort of thing. So I've been put in the right position to be able to kind of grow this type of practice and knowledge and that sort of thing. So, yeah.
Cool.
Yeah. but we're getting away from questions, and you've done a really good job so far. But we'll keep pushing here and maybe switch away a bit from pneumonia specifically, because I think we've only gone to a handful of questions, and I still have lots more.
Okay.
So
hit me.
So again, going back to one I kind of maybe brought up before, but what antibiotic has the highest risk of causing C. diff infection? What is associated with the highest C. diff infection risk?
Clinda.
Bingo. Yeah, Clinda sucks, to put it elegantly. Yeah, don't like clindamycin. Don't like when I see it unless there's a really good reason for it. It definitely has the highest. Some other well-known antibiotics that are known to have a higher C. diff risk is cephalosporins and fluoroquinolones.
Oh.
Also have quite a big risk. I think when we think of those fluoroquinolones, particularly because they're quite broad spectrum, and some of the later gen cephalosporins, same sort of thing. C. diff infection, most people, I think a decent amount of people are colonized with C. diff, but it's almost like an opportunistic infection. When you clear out the good bacteria in your gut that are kind of competing with the C. diff, it allows it to take hold. So I think when we use broad spectrum antibiotics, you are posing more of a risk.
Okay, so those other ones are a risk because they're somewhere in the middle between a Clinda and a like narrow spectrum beta lactam in terms of they're like broad.
Yeah, and again, any antibiotic has that potential risk, except for like vancomycin, because you use vancomycin to treat C. diff.
Right.
But it's yeah. So that's, again, Clinda, not a good one, not super useful. And again, another reason why dentists, at least in BC, seem to be shying away from it, which is great.
Excellent.
Mm-hmm. Okay, moving on to a different class of antibiotics, the macrolides. So one of the macrolides are generally safe options, even though I just absolutely roasted azithromycin. I do like azithromycin when it's used in the right time and right place. But with macrolides, one of their concerns is risk of QTC prolongation, which of course can lead to things like torsade de pointe, which is dangerous. But of the three main macrolides, clarithromycin, erythromycin, and azithromycin, which of those has the highest risk of QTC prolongation?
Clarithro?
Yeah, yes. Clarithromycin does seem to have the highest risk, and then that risk drops a little bit for both erythromycin and azithromycin. They're considered roughly equal. But yes, clarithromycin also is more of a CYP3A4 inhibitor, and as we probably all know, that is like the enzyme class that seems to metabolize almost every drug, it seems, which is why no one on any medication can really drink grapefruit juice. So that's another reason why it's not super fantastic. Azithromycin does inhibit that as well and has that QTC risk, but it's lower, which is nice. There is another major class of antibiotics that are prone to QTC prolongation. Do you know which one that is?
I know that it exists, but I don't remember what it's called.
Fluoroquinolones, they're also pretty, have a QTC prolongation risk as well.
Okay.
Yeah. Okay.
Moxifloxacin, levofloxacin.
Mm-hmm. Yes, I think those in particular.
Okay.
Or actually, Moxie is I recently had to look for a patient of mine and delve into it because it was such a complicated circumstance. Anywho, I believe based on the data, Moxie has the highest risk within that family, and I think Levo has the lowest for whatever reason.
Okay. You know what? In my head, I was going doxycycline, but I knew that was wrong.
You got it was the oxy. You had the oxy for sure.
Yeah.
Definitely. Okay. Again, moving on to kind of these like specific drug class based questions. Which of the tetracyclines is associated with drug-induced lupus?
Which of the tetracyclines? Can you remind me what the tetracyclines are?
For sure. So tetracycline, doxycycline, and minocycline. Those are the three main. I don't even know. I'm not sure if there's actually other ones.
Minocycline?
Yeah. Minocycline, another one I don't like. Minocycline does come with that risk, among other things. It's definitely associated with the highest risks within that family of just different issues, one of them being drug-induced lupus.
And like liver problems too?
Yeah, so it can cause some liver trouble as well. You're right.
Liver trouble.
So
I know that in my bones because I was trying to get like life insurance or disability insurance right out of school, and I was on minocycline at the time, and then they tried to say that I had liver dysfunction, and I was like, despite being a university student and drinking not just the odd time, but like pretty frequently, I know I don't have liver dysfunction. Like, let's do that again.
That's not right. So if I may ask, if it's not too personal a question, what were you using the minocycline for?
For perioral dermatitis.
At
the time.
Yeah, so that's actually something I've seen quite a lot recently. And you're right, tetracyclines are a useful group for that and for acne, not only because they have some antibacterial effect, obviously, but they also have anti-inflammatory effect, which is why they're useful. But the thing is, at least according to our, again, the data, for the longest time, I think, again, I'm newer to the practice, but I think minocycline was seen as like the one to use for things like acne, for things like rosacea, for things like this. But at least in acne, and I would believe it would follow the other ones as well, there's no major difference in effect between the tetracyclines.
Gotcha.
So when I see a prescription for minocycline, I'm like, why this one when it has the highest risk of problems? With acne, it has the highest risk of like hyperpigmentation and like those blue-black acne scars that like doxycycline and tetracycline don't have, and they work just the same. So it's another one of those ones where I'm like, why? Why are we doing this?
It would be interesting to see, like, I don't know if anyone has ever done this, but tracking when antibiotics came out onto the scene, or like any drug, like find them on a calendar, like this came out in this year. What is the age of this doctor, and were they like peak career, and are they still prescribing it? Because like I want to say, I don't know when azithromycin came out, but I want to say that it was still brand name somewhere around like 2011, and it was still came out in a Z pack. And I know that because I was getting strep throat every other week. Like it was horrendous. I was just worn down in my first degree. And so, but I remember it being like it was the hot drug on the block. And so I feel like some doctors, they just get used to prescribing something.
Yeah, totally. And yeah, it's interesting that you mentioned that for strep, because that was one of my other questions. Is azithromycin a good option for strep?
I want to say it's not at this point.
Yeah. So again, based on everything I've said, which has been just, it's a good thing it's not a brand name anymore, because the brand reps would want to stay away from me. But azithromycin, also not good coverage of group A strep, which is what causes strep throat. It's like I'm looking right now at the antimicrobial dashboard for BC, and as of 2024, only 69% of strains, that's strep pneumo, there you go. 76% of group A strep is sensitive to azithromycin. So like that's not bad, but when we consider the other first line choices, which was my next question, it makes no sense why we're using it regularly. Maybe when we were using it 10 years ago, not to age you or anything, but when it was being used, like maybe it was extremely sensitive. Like maybe there wasn't these resistant patterns, but then they grow when we use them too much. So it's very interesting, because maybe at the time, that was the right decision. It's just not really the best decision right now.
Right. It's very easy for us to look back and say, oh, well, we have new information now. And so therefore everybody was wrong back then. But who knows? Maybe it was a better choice. Although I have to say, I mean, it was brand name at the time. So I feel like there was a huge drug rep situation going on.
I'm sure there was. Absolutely. So with strep, that's a really good jumping off point, because this is also something I see prescribed incorrectly a lot of the time. What are the drugs of choice? There are two main drugs of choice for treating group A strep or pharyngitis. So what is that, and what is the preferred dosing? Multi-layered question.
10 VK.
Yep.
600 twice a day?
Yeah, absolutely. Yep. Nailed it.
What's the other one? That's all I got.
No, I think that was great. So you're absolutely right. PenVK, far and away the best. We also consider amoxicillin. Amoxicillin is also extremely sensitive. So again, going back to the antimicrobial resistance dashboard, 100% of strains of Group A strep are sensitive to both PenV and amoxicillin.
100%?
100%. So
Damn.
so that again is the funny thing. You're right. Resistance patterns change, but the fact that we've had penicillins for so long and there is zero resistance, roughly, to these drugs, why are we not using them every single time?
That's pretty incredible.
Yeah. So you're right. For PenVK, it's 600 milligrams twice a day. As for amoxicillin, this is one I see wrong a lot of the time, because I think if we're all thinking of just your generic amoxicillin prescription, what are we seeing? We're seeing 500 milligrams 3 times a day, right? That's like the one. That is not the right dosing for strep. Because it's so sensitive, all you need is 500 milligrams twice a day.
Okay.
But so often I see people come with that generic script and like, what are you using it for? Strep throat. I'm like, no, okay. You don't need to do that. And oftentimes I'll adapt it and fix the dosing. Especially if they like said, yeah, I did a swab. It was strep. Great. Change it.
Okay. So it's strep and just pharyngitis.
Mm-hmm.
And you get an amoxicillin 3 times a day, 500 milligrams, you're feeling quite confident in adapting that down to twice a day to save them maybe some GI effects.
Yeah, especially if it was like an ER doc, so I can look at their like through Care Connect and BC, we can access like medical notes. So if there's something there that says, yes, we did a test, it was strep, I'm like, yeah, absolutely. If the patient or the patient's guardian, because it's mostly children, like are good historians, and they say, yes, we did a strep test and it came back positive, then I'm like, yeah, okay, then I feel comfortable. A lot of the time people don't know and they're just given amoxicillin for like, oh, I have like maybe tonsillitis or I have some sort of throat issue. I'm not going to touch that because I don't know for sure, but I'm usually pretty confident with that. So yeah, that's one for people to keep an eye out for. And the max dose is 1,000 milligrams a day, child or adult, for strep with amoxicillin.
That's specifically for strep. That's your max dose.
Specifically for strep. Otherwise, for most anything else, the max dose is 4,000 milligrams. So again, it's this huge range. But just the fact that Group A strep is so susceptible that you only need a quarter of the max daily dose, it's quite fascinating to me.
That's
and
handy.
How little it's used. But the other important part of that is the duration. How long are we supposed to treat strep throat for with these penicillin antibiotics?
I mean, it sounds like it's very susceptible, so I would be going fairly short course, like 5 days?
Mm-hmm. That logic is great. Unfortunately,
it's wrong.
It's the opposite. You want to treat for 10 days. There is a specific reason for that. That reason being, so you're right, they're super susceptible, but we're not actually necessarily treating the infection at that point. We're using a 10-day course to prevent acute rheumatic fever. Oh, that is something that can happen when your body responds to that specific bacteria. It just produces a really dangerous immune response. So as long as we start these penicillins within 9 days of symptom onset, and we do it for 10 days, we're greatly dropping that risk. So once again, that's another thing I see that's often wrong. Even if they dose it correctly, and again, most of the time I'm seeing an antibiotic prescription for amoxicillin, it's 500 milligrams 3 times a day for 7 days. But if it's for strep throat, we know that, well, even though the daily dose is too high, it's actually not long enough. So that's another one I adapt fairly regularly if I have, of course, the right information about it.
Interesting, because as a general rule, you would think the dose is too high and the duration is too long, and those tend to go together. But for strep throat, which we have minor ailment prescribing rates,
we do not actually.
They have it in Ontario, I think.
I believe they do have it in some different areas, and it would definitely make sense. I know, obviously, pharmacies can do strep throat testing. Not one of the ones in BC as of date of record, December 18th. So, yeah. So that's one of the other areas and tangents that my colleagues will hear from me a lot. Being like, oh, this doctor did amoxicillin 3 times a day for strep throat. So I must be really awful to work with. But...
I mean, it sounds like you're doing really great work. And a little sass goes a long way to make people all feel like they're part of a big team.
Yeah, good. Well, I'm glad. I hope it's not off-putting. Yeah, so let's see. There's so many great questions. I think we've focused on a lot of things. What are some other things I see misprescribed fairly often? Okay, staying in sort of the respiratory infection, because we are really in that season right now. Oftentimes, we're using, again, amoxicillin for otitis media, bacterial sinusitis, and pneumonia. And sometimes we consider a regimen called high-dose amoxicillin. But when are we considering high dose? Like when and why would we consider this higher dosed regimen?
The only one I remember is for otitis media in little kiddos. And I want to say it has to do with like their eustachian tubes are so wonky that you have to get higher dose in there or something. Or they're just like more susceptible to resistance. I don't know.
Yeah, yes and no. So you're right. The kids, you're right, do have like kind of a weird eustachian tube. But I don't think that necessarily affects the drug resistance. We're usually considering this high dose, which again, you're right. We absolutely almost consider it always in children, especially because in otitis media and sinusitis, it's like almost only children that get a true bacterial infection with those. But it's so we can overcome PRSP resistance, which is penicillin-resistant strep pneumo. So there is still resistance to strep pneumo, but we can actually override it and overcome that if we dose the drug high enough.
Gotcha.
So in kids, we're usually targeting 90 mg per kg per day, divided however you want. Some of them, like RX files, some resources will say 75 to 90. The worst thing is when I get a prescription for a kid for amoxicillin for one of these upper respiratory tract issues, and it comes to like 60 mg per kg per day, because the standard dose is about 40 to 50, and high dose is 75 to 90. So 60 is literally right in the middle. So I'm like, what are you doing? what are we trying to achieve? So oftentimes that's when we'll kind of switch. And there's criteria to determine when we do that. So the kids that are at increased risk for this penicillin-resistant strep pneumo, it's if they're less than 2, if they're under or simply unimmunized, and if they've had antibiotics in the last 3 months. And then kind of one that's, I don't know, kind of hit or miss is if they're in daycare, because daycares are cesspools. Nobody's fault, but I'm sure you know, and I know you know that's the case.
That is accurate. Oh my God.
Mm-hmm.
I mean, a huge part of why I'm not back at work right now in a dispensary is, so first of all, daycares can set their own hours. I have exactly 8 hours of daycare a day. So like
no more, no less.
Between drop off and pick up, which is a full hour of my day, then I'm supposed to go work like a 6-hour shift in a community pharmacy that already has like funding and staffing problems. Good luck. And then, the first 6 months of her being in daycare, she was sick. I'm going to say every 2 weeks, conservatively, she was off sick. At least 1 or 2 days every 2 weeks. So good luck. I actually was supposed to go back to work for 2 days a week. And I just, I was like, well, I can go back to 2 days a week. That feels like very manageable. And then I messaged the potential employer and was like, you're just going to want to take a hard left here. Like, it's not going to go well for you. I'm going to be the worst employee ever.
Gonna have to go. And at daycare, I know I have some colleagues with daycare. They're like, oh, they're sick today. And then you're gone. So it's like you got to pick them up. So yeah. So daycare, all of that to say, yes, they're sick all the freaking time, which is why they do have increased risk of these resistant bugs. So we have to generally consider a higher dose. My professor at UBC, when she was teaching this, Roxanne Carr, an amazing pediatric pharmacist that works at BC Children's.
Oh, had Roxanne teach you antimicrobial stuff?
She did. One of my students, the students we had at our store recently, is currently in January we'll be doing his, shout out to Sam, his hospital placement or his specialty placement? No, hospital, with Roxanne, which I think is so cool. I'm so jealous. Anyway, I know, she rocks. So Roxanne, what's up if you're listening? You rule.
Roxanne.
Get on the pod. But she kind of mentioned with amoxicillin, when patients come in, I've always remembered this. When patients come in and they're like, "Oh my gosh, my child drank the whole amoxicillin suspension," the concern is more, okay, well, we should get them some more rather than, "Oh my God, they're going to overdose," because that's how safe it is.
Right.
It's
Okay.
usually more of a, "Oh, we just need to get you more so you can finish the course," versus you're, at risk. So that's why I also feel fairly comfortable when I do have to adapt and increase either the duration or the dose based on these different protocols and recommendations from our guidelines, because I know amoxicillin is generally very, very safe.
Excellent. Yeah,
Yeah.
I know as pharmacists, and maybe this is just me, but I often feel squeamish about increasing a dose of something
Mm-hmm.
versus like backing off a dose. I always have
Totally.
felt a little bit more confident on that. Um, and so the daycare cesspool indication, is that sort of like clinical expertise dictating that, or is that like written somewhere?
It is written specifically in guidelines. If you go to Bugs and Drugs or you go to Rx Files, again, my Bibles, uh, not to be sacrilegious, but that they do specifically say daycare. I think what's kind of weird though is like what totally constitutes daycare, because like I'm sure it's not that much better for a 5-year-old in kindergarten. Like I'm sure that's also not like the most clean place.
Mm,
So again, I think it's more with the wording, but technically it is written into the guidelines that daycare, yes, if they're in daycare, they should be considered.
right, right. Well, I have a bit of insight into this because
Mm.
um, daycare is so hard to find. I'm doing my ECEA course to be able to um, distinguish myself as a parent who could like help out if they have
Oh,
staffing problems.
wow.
That's how I've managed to secure daycare for myself. Um,
That's the only way.
yeah, yeah, it's brutal out here. Um, and younger centers with younger children generally have more germs going around, and I think that has to do with their less mature immune systems. So there's even different cleaning protocols
Mm,
because it's just lower risk for them.
right.
So the younger centers have to, or they're supposed to clean everything in the center, toys and everything daily, whereas if you
Mm.
look at an older center like 3 to 5 year olds, it's once a week. Um,
Interesting. Okay, that's really good context, because what do I know? I'm a dink, a dual income, no kids person right now, which is great.
love that for you.
Love being a dink. Probably won't last forever. But that is really interesting because I have very little insight into that. So I will definitely use that. All right, awesome. Okay, this is an interesting one that came up recently at the store for me. Um, so again, we've talked a lot about resistance. So obviously, one of the big scary ones is MRSA, methicillin resistant Staph aureus, so MRSA. Obviously, because it's extremely resistant, it's very hard to find good drugs against it, especially in outpatient settings, where again most of the useful bacteria or most useful antibiotics against MRSA are like IV, so like vancomycin, or why can't I not think of any of the other ones? But I mainly think vancomycin. But most of the things are very broad spectrum that have to cover them. But there are still some useful oral options. So, what are 2 useful oral options that you can actually use against a relatively uncomplicated MRSA infection?
Relatively uncomplicated MRSA.
Like I'm thinking like not somebody who has sepsis, but maybe somebody who has like a skin infection that they found MRSA in.
Amoxiclav?
Nope, unfortunately
No.
not methicillin resistant. So it's basically like almost all penicillin or all beta lactams. Most
Argon.
are gone. Mm-hmm.
Skin infection? You're gonna have to just tell me the answer.
For sure. So again, back to the dashboard. So you write vancomycin, great option, 100%. That is not oral. Well, it can be oral, but it's not going to get absorbed into the body, so you can't use it for a skin infection. I'm looking again, even some of our carbapenems, like ertapenem or meropenem, are resistant. However, doxycycline and sulfatrim actually have really good effect, at least in
Oh.
BC. Sulfatrim in 2024 had an 86% susceptibility of cultured and tested bugs, MRSA, and doxycycline was 91.
Whoa.
Yeah, like shockingly high. I think, again, for a long time, clindamycin was also considered, again, my favorite, which is technically true, but resistance is growing. It's at 73% right now, so definitely not as good. But yeah, doxy and sulfatrim, oddly very, very good against MRSA, which is great because those are two very common oral options. That could just be BC. I don't know what the rest of the landscape looks like in Canada, but here it's actually really good.
Oh, interesting. Okay, that's good to know.
Yeah. So that I think is an interesting one that came up for me recently. Let's see what else. Oh, one that does come up very often because in BC pharmacists can assess and prescribe for especially uncomplicated UTIs, which is probably the most common thing I do with my minor ailments. The drug of choice, I will just spoiler alert, the drug of choice is nitrofurantoin or macrobid. But why is it so useful for uncomplicated UTIs? And why is it not useful for infections of the upper urinary tract, like pyelonephritis, which is a kidney infection?
Something to do with it being excreted with an active metabolite in urine or something like that. I remember it concentrates in the urine.
Yeah, you're absolutely right. So for the longest time, I also thought, 2 years or so, I was also thinking that it had something to do with how it gets activated into the activated when it reaches the bladder. That's not technically true. It's not an active metabolite that's working against it, but you're right. Our body is so good at filtering it out. It really only reaches therapeutic concentrations in the urine, which is exactly where we want it to be. But because it only concentrates there and our kidneys are so good at removing them, the rest of the body isn't getting them, which means the kidney also does not get them.
Gotcha, because you're trying to get into the kidney tissue.
Yeah, exactly. You need to get into the tissue, not just into the lumen. So, it's only good for bladder and lower. The other reason we always use it as a first line, because other things will get into the urine in enough concentration. A lot of drugs do. Why macrobid or nitrofurantoin? It's because far and away, just like with our pneumonia, we have one that's the most common cause. In uncomplicated, healthy people, it's E. coli that is the most common cause. And there's virtually no resistance to nitrofurantoin. Here on the island, it's virtually zero, 100% susceptibility. As for BC proper, if I'm looking here, it's 97%. So we like it because it's very safe. It basically only accumulates in the urine, which is where we want it, and it's extremely effective against the main bug we're using.
Cool. Okay, that's a good refresher.
Mm-hmm. Yeah, because I feel like that's one that comes up quite often. Another thing I find very interesting is the use of Cipro in bladder stuff, UTIs, kidney infections especially. I think this has been pulled back a bit. I don't think we see it nearly as often. But before I really looked into, again, the resistance patterns, I was like, Cipro is a great option. It's just, it's more broad spectrum. We don't want to use that unless we have to, but it is a good option. But if you actually look, its coverage of E. coli is not as good as you think it would be. You would assume that, yes, it's good against a lot of the gram-negative bugs and Enterobacteriaceae, which are the bugs that live in the GI tract that often colonize and cause these infections in the urinary tract. It's broad spectrum, so it works against all of them really well. But its coverage of E. coli is 63% in BC as of 2024. Whoa. Way lower than I certainly expected. I figured it would be a great choice. But the reason we're using Cipro in more severe kidney and more complicated infections is not because of its E. coli coverage. It's because of the coverage of other bugs that could be causing it.
Oh, okay. Gotcha.
Yeah, which is, again, interesting, and I didn't know. So, I think I have other questions, but I can save them possibly for another time if you would consider having me again.
We can do a follow-up.
Yeah, but how are you feeling? I think you did really well. I think you answered most of the questions correctly.
I'm feeling
overwhelmed.
Yeah, I mean, it's funny because I feel the least confident about antibiotics out of all the topics, but you see them so often in practice, and so the pattern recognition is there once you remember what they're called. Mm-hmm. But yeah, I think you think I did well on some of this, but it was purely vibes. I was like, this one feels right.
Mm-hmm.
Yeah.
That's part of being a good clinician, is feeling out the vibe. You know,
Is the vibes,
you
yeah.
had it in your brain. It was just way in the back.
It was so
But-
far back. Yeah.
Yeah.
Poor Lindsay Dixon is like, no, science, not vibes.
Yeah, well, you kind of gotta vibe out sometimes in community practice. You just gotta.
Yeah, exactly. Yeah, well, that was really great. A good refresher. For me, as I stand today, like sulfatrim, have not heard that word in 3 years.
Really? Because that's
So
actually
that's-
pretty common. Believe it or
But
not.
I'm not in the dispensary, right?
You're so right. Yeah. But yeah,
so it's
sulfatrim.
like, that's a huge part of why I'm doing this podcast is I want up-to-date information and clinical information, but I also just need to remember drug names
Yeah,
and
yeah.
be able to pull them and
There's
get
so
those
many.
patterns back into my head, you know, for when I'm not in my kid having years and want to be a part of society again.
Yeah. Welcome back.
Well, thank you very much for coming on and quizzing me.
Yeah,
This has been great.
Thank you so much for having me. Thank you for letting me rant about antibiotics. I normally have a platform for it at work, but all those people are tired about hearing of it. So I appreciate that you let me do it for you and your listeners. But yeah, I really enjoyed it. This was really fun. I love talking antibiotics because it's definitely my area that I really feel good about. Don't ask me anything about anything dermatology. I am useless. But antibiotics, I do really enjoy.
Perfect. Well, we'll have you back with more questions later. And
Awesome.
Yeah, I think this is really good that you are willing to lend some confidence to other pharmacists in the province to maybe up their game on adapting and, you know, clapping back at bad prescribing practices. So thanks again.
Yeah, thank you for having me.